Hi and welcome back to another video of Medic Notes. This video is on acute liver failure. Acute liver failure is caused most often by drugs and hepatitis viruses. Cardinal manifestations are jaundice, coagulopathy, and encephalopathy. Diagnosis is clinical. Treatment is mainly supportive, sometimes with liver transplantation or specific therapies, such as NAC for acetaminophen toxicity. Overall, the most common causes of acute liver failure are viruses, primarily hepatitis B, and drugs and toxins, most commonly acetaminophen. In countries with poor sanitation, viral hepatitis is usually considered the most common cause. Whereas in countries where there is effective sanitation, toxins are usually considered the most common cause. Overall, the most common viral cause is hepatitis B, often with hepatitis D co-infection. Hepatitis C is not a common cause. Other possible viral causes include cytomegalovirus, Epstein-Barr virus, herpes simplex virus, human herpesvirus 6, parvovirus B19, varicella-zoster virus, hepatitis A virus, hepatitis E virus, and viruses that cause hemorrhagic fever. Whereas for toxins, most common toxin is acetaminophen. Predisposing factors for acetaminophen-induced liver failure include pre-existing liver disease, chronic alcohol use, and use of drugs that induce the cytochrome P450 enzyme system. Other toxins include antibiotics, halothane, iron compounds, isoniazid, NSAIDs, some compounds in herbal products, and Amanita phalloides mushrooms. Some drug reactions are idiosyncratic. Other less common causes are vascular disorders, such as hepatic vein thrombosis or Budd-Chiari syndrome, ischemic hepatitis, portal vein thrombosis, hepatic sinusoidal obstruction syndrome, or hepatic veno-occlusive disease. Metabolic causes such as acute fatty liver of pregnancy, HELLP syndrome, Reye syndrome, and Wilson disease. And also other causes like autoimmune hepatitis, metastatic liver infiltration, heat stroke, and sepsis. In acute liver failure, multiple organ systems malfunction, often for unknown reasons and by unknown mechanisms. Affected systems include hepatic. Hyperbilirubinemia is almost always present at presentation. The degree of hyperbilirubinemia is one indicator of the severity of liver failure. Coagulopathy due to impaired hepatic synthesis of coagulation factors is common. Hepatocellular necrosis, indicated by increased aminotransferase levels, is present. Cardiovascular. Peripheral vascular resistance and blood pressure decrease, causing hyperdynamic circulation with increased heart rate and cardiac output. Cerebral. Portosystemic encephalopathy occurs, possibly secondary to increased ammonia production by nitrogenous substances in the gut. Cerebral edema is common among patients with severe encephalopathy secondary to acute liver failure. Uncal herniation is possible and usually fatal. Renal. For unknown reasons, acute kidney injury occurs in up to 50% of patients. Because blood urea nitrogen level depends on hepatic synthetic function, the level may be misleadingly low. Thus, the creatinine level better indicates kidney injury. Immunologic. Immune system defects develop. They include defective opsonization, deficient complement, and dysfunctional white blood cells and killer cells. Bacterial translocation from the gastrointestinal tract increases. Respiratory and urinary tract infections and sepsis are common. Metabolic. Both metabolic and respiratory alkalosis may occur early. If shock develops, metabolic acidosis can supervene. Hypokalemia is common, in part because sympathetic tone is decreased and diuretics are used. Hypophosphatemia and hypomagnesemia can develop. Hypoglycemia may occur because hepatic glycogen is depleted and gluconeogenesis and insulin degradation are impaired. Pulmonary. Non-cardiogenic pulmonary edema may develop. For the signs and symptoms, characteristic manifestations are altered mental status and jaundice. Manifestations of chronic liver disease such as ascites argue against the acuity of the condition but can be present in subacute liver failure. Other symptoms may be nonspecific such as malaise and anorexia. Fetor hepaticus, a musty or sweet breath odor, and motor dysfunction are common. Tachycardia, tachypnea, and hypotension may occur with or without sepsis. Signs of cerebral edema can include obtundation, coma, bradycardia, and hypertension. Despite prolonged INR, bleeding is rare unless patients are in disseminated intravascular coagulation. For diagnosis, prolongation of INR to 1.5 and more, and clinical manifestations of encephalopathy in patients without prior history of chronic liver disease. To determine the cause, ask history of drug use, exposure to toxins, hepatitis virus serologic tests, autoimmune markers, and other tests based on clinical suspicion. Acute liver failure should be suspected if patients without underlying chronic liver disease or cirrhosis have acute onset of jaundice or elevated transaminases that is accompanied by coagulopathy and mental status changes. Patients with known liver disease who acutely decompensate are not considered to have acute liver failure but rather acute on chronic liver failure, which has different pathophysiology from that of acute liver failure. Lab tests include liver enzyme, bilirubin levels, and INR. Acute liver failure is usually considered confirmed if sensorium is altered and INR is more than 1.5 in patients who have clinical or laboratory evidence of acute liver injury. Evidence of cirrhosis suggests that liver failure is chronic. Patients with acute liver failure should be tested for complications. Tests usually done during the initial evaluation include complete blood count, serum electrolytes, renal function tests, and urinalysis. If acute liver failure is confirmed, ABG and blood type and screen should also be done. Plasma ammonia is recommended to help predict prognosis because higher ammonia levels predict increased risk of cerebral edema. If patients have hyperdynamic circulation and tachypnea, cultures and chest X-ray should be done to rule out infection. If patients have impaired or worsening mental status, particularly those with coagulopathy, head CT should be done to rule out cerebral edema or less likely intracranial bleeding. Viral hepatitis serologic tests. Autoimmune markers. Ceruloplasmin level if suggestive for Wilson's disease. Ultrasound for suspected structural abnormalities. For treatment, supportive measures. For hypotension and ACI. For encephalopathy. Treat infection. Correct electrolyte deficiencies. Treat hypoglycemia. Treat coagulopathy with FFP if indicated. Nutritional support. N-acetylcysteine for acetaminophen toxicity. And sometimes liver transplantation. That's all for this video. Thank you.